Continuing on with Chapter 33, for newborn assessment and resuscitation, follow standard precautions. Always put gloves on before handling a newborn. A newborn will usually begin breathing spontaneously within 15 to 30 seconds after birth, and the heart rate will be 120 beats per minute or higher. If you do not observe these responses, gently tap or flick the soles of the feet and rub the back, not like scrubbing off skin rubbing, but just gentle rubbing, typically with a towel, will be enough to stimulate the newborn. Many newborns require some form of stimulation that will encourage them to breathe air and begin circulating blood through the lungs, including positioning of the airway, drying, warming, suctioning, and then that tactile stimulation of flicking the heels. To maximize the effects of these measures, follow these tips. Position the newborn on his or her back with the head slightly down and the neck slightly extended. Place a towel or blanket under the shoulders to help maintain this position. If necessary, suction the mouth and then nose using a bulb syringe or suction device with an 8 or 10 French catheter. Suction both sides of the back of the mouth, but avoid deep suctioning of the mouth and throat. Aim blow-by oxygen at the newborn's mouth and nose during resuscitation. In addition to drying the newborn's head, back, and body vigorously with dry towels, you may rub the newborn's back, flick, or slap the soles of his or her feet. We don't do the whole upside down spanking of the baby anymore. That's not at all what we do. So don't do that. Here's a table that's provided in your book. You can go ahead and review that on your own. Observe the newborn for spontaneous respiration, skin color, and movement of the extremities. Evaluate the heart rate by palpating the pulse at the base of the umbilical cord or even at the brachial artery, or listening to the newborn's chest with a stethoscope. The heart rate is the most important measure in determining the need for further resuscitation. If chest compressions are required, use a hand encircling technique for two-person resuscitation. Perform BVM ventilation during a pause after every third compression using a compression to ventilation ratio of 3:1. This will yield a total of 120 actions per minute, 90 compressions, and 30 ventilations. And here's the graphic that's showing you what to do when the heart rate is not where it should be. Here's the two thumbs encircling technique where you're actually either putting your thumbs side by side or overlapping depending on the size of the newborn. Any newborn who requires more than routine resuscitation requires transport to a hospital with a level 3 neonatal intensive care unit. About 12 to 16% of deliveries are complicated by the presence of meconium. If you see meconium in the amniotic fluid or meconium staining and the newborn is not breathing adequately, consider quickly suctioning the newborn's mouth, then nose after delivery before providing rescue ventilations. The APGAR score is a standard scoring system used to assess the status of a newborn. It assigns a number value 0, 1, or 2 in 5 areas of activity. Appearance: the skin of a light-skinned newborn, the mucous membranes of a dark-skinned newborn should turn pink. Blue all over or blue mucous membranes are a sign of central cyanosis. Pulse: if a stethoscope is unavailable, you can measure pulsations with your finger in the umbilical cord or at the brachial pulse in the upper arm. A newborn with no pulse requires immediate CPR. Grimace or irritability: grimacing, crying, or withdrawing in response to stimuli is normal in a newborn and indicates the newborn is doing well. The best way to tap this is to snap a finger against the sole of the newborn's foot. Activity or muscle tone: the degree of muscle tone indicates the oxygenation of the tissues. Normally, the hips and knees are flexed at birth, and to some degree, the newborn will resist straightening them out. A newborn should not be floppy or limp. For respirations, normally a newborn's respirations are regular and rapid with a good strong cry. If the respirations are slow, shallow, or labored, or if the cry is weak, the newborn may have had respiration insufficiency and need assistance with ventilation. Complete absence of respirations or crying is a very, very serious sign. The total score of the 5 numbers is the APGAR score. A perfect score is 10. Calculate the APGAR score at 1 minute and 5 minutes after birth. Here's a graphic of the APGAR score that's provided for you in your text. You can go ahead and review that on your own. Follow these steps in assessing a newborn. Quickly calculate the APGAR score to establish a baseline of the newborn status. Stimulation should result in the immediate increase in the respiratory rate. If not, you must begin ventilations with a VM. If the newborn is breathing well, you should next check the pulse rate by feeling the brachial pulse or the pulsations at the base of the umbilical cord, or by auscultating the chest with a stethoscope. The pulse rate should be at least 100 beats per minute. If not, begin ventilations with BVM. Reassess respirations and heart rate every 30 seconds. Assess the newborn's oxygen via pulse oximetry and observe for central cyanosis. If present, administer blow-by oxygen by holding an oxygen tubing at high flow close to the newborn's face. Set oxygen flow rate at about 5 liters per minute. You should request a second unit as soon as possible if you determine that the newborn is in any distress and will require resuscitation. In situations where assisted ventilation is required, you should use a newborn bag valve mask. Make sure you have a good mask to face seal. Use gentle pressure, making the chest rise only to chest rise in ventilation. If the newborn does not begin breathing on his or her own and does not have an adequate heart rate, consider CPR and rapidly transport. Once CPR has been started, do not stop until the newborn responds or is pronounced dead by a physician. Complicated deliveries. The presentation is the position in which the infant is born or that body part that's delivered first. Most infants are born head first, called the vertex position. Occasionally, the buttocks are delivered first, called breech presentation. The fetus is at greater risk for trauma from delivery. Prolapse cords are more common from breech deliveries. Breech deliveries usually take longer, so you'll often have time to transport the pregnant woman to the hospital. However, if the buttocks has already begun to pass through the vagina, the delivery has begun. Provide emergency care and call for ALS backup. If the woman does not deliver within 10 minutes of a buttocks presentation, provide prompt transport. Consult medical control to guide you. Preparing for a breech delivery is the same as for normal childbirth. Position the pregnant woman, prepare the OB kit, place yourself and your partner as you would for a normal delivery. Allow the buttocks and legs to deliver spontaneously, supporting them with your hand to prevent rapid expulsion. Let the legs dangle on either side of your arm while you support the trunk and chest as they're delivered. The head is almost always face down and should be allowed to deliver spontaneously, aka don't pull. Make a V with your gloved fingers in the position of the vagina to keep the walls of the vagina from pressing against the fetus's airway. On rare occasions, the presenting part of the fetus is neither the head nor the buttocks, but a single arm, leg, or foot. This is called limb presentation. An infant with limb presentation cannot be successfully delivered in the field. Usually surgery is needed. You must transport the patient to the hospital immediately. If a limb is protruding, cover it with a sterile towel. Never try to push it back in and never pull on it. Place the patient on her back with her head down and pelvis elevated. Remember to give the woman high flow oxygen. Prolapse of the umbilical cord is where the umbilical cord comes out of the vagina before the fetus does and must be treated in the hospital. The fetus's head will compress the cord during birth and cut off circulation to the fetus, depriving it of oxygenated blood. Do not attempt to push the cord back into the vagina. There is usually time to get the patient to the hospital. Your job is to try and keep the fetus's head from compressing the cord. Place the pregnant woman supine with the foot of the cot raised 6 to 12 inches higher than the head, with her hips elevated on pillows or folded sheets. Alternatively, the woman may be placed in the knee to chest position, kneeling and bent forward face down. Either of these positions will help keep the weight of the fetus off of the prolapse cord. Carefully insert your sterile gloved hand into the vagina and gently push the fetus's head away from the umbilical cord. Wrap a sterile towel moistened with saline around the exposed cord and give high flow oxygen and transport rapidly. Spina bifida is a developmental defect in which a portion of the spinal cord or meninges may protrude outside of the vertebrae and possibly outside of the back. When it protrudes outside of the body, it is seen on the newborn's back and usually occurs in the lower third of the back in the lumbar area. Cover the open area of the spinal cord with a sterile, moist dressing immediately after birth to prevent potentially fatal infection. Maintenance of the newborn's body temperature is important when applying moist dressings because the moisture can lower the newborn's body temperature. Have someone hold the newborn against her body. Multiple gestation. Twins occur in about every 30 births. Usually multiple fetuses are diagnosed early in pregnancy with modern ultrasound techniques. With multiple fetuses, always be prepared for more than one resuscitation and call for assistance. Twins are usually smaller than single fetuses, and delivery is typically not difficult. Consider the possibility of twins at any time for a first newborn is small, or the woman's abdomen remains fairly large and firm after birth. If twins are present, the second one will usually be born within 45 minutes of the first. About 10 minutes after the first birth, contractions will begin again and the birth process will repeat itself. The procedure for delivering twins is the same as that for a single fetus. However, you will need some supplies from an additional OB kit. Clamp and cut the cord of the first newborn as soon as it's been born before the second newborn is delivered. There may be only one placenta or there may be two. Record the time of birth for each twin separately. Twins may also be small that they look premature. Handle them carefully and keep them warm. A premature birth. A normal full-term single newborn will weigh approximately 7 pounds at birth. Any newborn who delivers before 8 months or 36 weeks or weighs less than 5 pounds at birth is considered premature. A premature newborn is smaller and thinner than a full-term newborn, and the head is proportionately larger in comparison with the rest of the body. The vernix will be absent or minimal on the premature newborn. There will also be less body hair. Premature newborns require special care to survive. They often require resuscitation efforts, which should be performed unless it's physically impossible. With such care, premature newborns as small as 1 pound have survived and developed normally. Postterm pregnancy refers to pregnancies lasting longer than 42 weeks. Postterm fetuses can be larger than the typical 40-week fetus, sometimes weighing 10 pounds or more. This condition can lead to problems with the woman and the fetus. These problems include a more difficult labor and delivery, increased chance of injury to the fetus, increased likelihood of cesarean section being required. The woman is at risk for perineal tears and infection. Postterm newborns have an increased risk of meconium aspiration, infection, and being stillborn. Newborns may not have been able to develop normally because of restricted size of the uterus. You should be prepared to resuscitate the newborn as respiratory and neurologic functions may have been affected. Fetal demise. You may find yourself delivering a fetus who died in the woman's uterus before labor. The onset of labor may be premature, but the labor will otherwise progress normally in most cases. If an intrauterine infection has caused the demise, you may note an extremely foul odor. The delivery of the fetus may have skin blisters, skin sloughing, or dark discoloration. The head will be soft and perhaps grossly deformed. Do not try to resuscitate an obviously dead neonate. On rare occasions, you may have to deliver the newborn without a sterile OB kit. Even without an OB kit, you should always have eye protection gloves and a protective mask with you. Carry out the delivery as if sterile supplies were available. If possible, use freshly laundered sheets and towels. As soon as the newborn is delivered, wipe the inside of the mouth with your finger to clear away blood and mucus. You should not cut or clamp the umbilical cord. Instead, as soon as the placenta delivers, wrap it in a clean towel, put it in a plastic bag, and transport it to the hospital. Always keep the placenta and the newborn at the same level or elevate the placenta slightly if possible, and keep the newborn warm. Bleeding that exceeds approximately 500 milliliters is considered excessive. If bleeding continues after delivery of the placenta, you should continue to massage the fundus. Check your technique and your hand placement if bleeding continues. Treat the woman as if she appears to be in shock. Excessive bleeding after birth is usually caused by the muscles of the uterus not fully contracting due to delivery of more than one infant, a long labor process that causes the uterus to be too tired to contract, parts of the placenta still being inside the uterus. Cover the vagina with a sterile pad, changing the pad as often as needed. Do not discard any blood-soaked pads. Hospital personnel will use them to estimate the amount of blood loss. Save any tissue that may have passed from the vagina. Administer oxygen if necessary. Monitor vital signs frequently and transport the patient immediately to the hospital. Never hold the woman's legs together or pack the vagina with gauze pads. Postpartum patients are at an increased risk of air embolism. The pulmonary embolism results from a clot that travels through the bloodstream, becomes lodged in the